We are starting, guys. Good morning and welcome to Medical Grand Rounds. So it's hard to believe we're like 3/4 of the year through and we're still doing no in-person Grand Rounds and still doing these Zoom things. I think at this point we're going to go through the academic year this way. And I don't know if things are going to be different in September. So we're just going with the flow. We have topics through June at this point. There is one date in the spring that I have open at this point. I'm not quite sure what to do at that point. If people think they need another COVID update around then, it's going to be April 1st week. We certainly have the time to organize and orchestrate that. If that's not needed, then we'll fill it up with something else. So if you have thoughts about what you'd like to see happen on April 1st, it's our only open date left through the spring. Shoot me an email or shoot me a text, and we can try to do what the majority wants. So today is our infectious disease case conference, and the presenter is known to all of you. Dr. Kate Hinkle is one of our ID consultants. I think she's been around with us now for what, 3 years, Kate? Or
almost, yeah, 2.5.
Yeah. So I think she's promised to keep us away from COVID, even though this is an ID conference. So with that, I'm going to let her take away the discussion.
Okay, thanks, Dr. Phatak. Good morning, everyone. So as you can see from the title slide here, I'm actually going to be talking about a difficult case of vertebral osteomyelitis, and it's one that is kind of still an active issue for me. So there'll be kind of ongoing discussion, I'm sure. I have to be honest, there's not a lot of, kind of groundbreaking information and new treatments. Vertebral osteomyelitis is a diagnosis that we've all dealt with for a long time. So this is more of a case to talk through, I think, some of the complications that we need to consider when we're treating these patients. And also a good time to just review the typical approach to managing these patients. As Dr. Phatak mentioned, just a spoiler alert: this is not a COVID case, not in any way. So this is just kind of an agenda of what I'm going to run through today. I will talk through most of the case up front, and then we are fortunate today to have Dr. Eric Spitzer joining us from radiology to go through the important images for this patient. And then after that, we'll kind of go through the main topics around vertebral osteomyelitis, including kind of the typical and atypical pathogens, as well as kind of the approach to diagnosis and at least kind of the early treatment and considerations that you need to have in mind. And towards the end, I'll actually talk about SERRATIA and some other gram-negatives because it's actually kind of the unusual pathogen that was involved in this case. And then we'll kind of summarize where the patient stands right now. So kind of jumping right into it, this gentleman is a 71-year-old male. He has a little bit of a past medical history I'll get to on the next slide, but his primary issue has been his low back pain. And he's had a number of surgical interventions for this, just kind of summarized here. So in the 1980s, he had his first lumbar disc herniation repair. We don't really have the records on that to know the details, but much more recently, we do. So in the last couple of years, he's been through several procedures. In July of 18, he had progressive left-sided L5 and S1 radiculopathy. And so he underwent decompressive laminectomy as well as resection of a synovial cyst at that point. He did okay for about a year, a little bit more than a year. And then eventually by November of 19, he was requiring a cane for ambulation. And this was mainly because he was having, again, left more than right-sided radicular pain, in addition to left-sided, left lower extremity weakness and foot numbness. And at that point, an MRI revealed a leftward L3, L4 disc herniation and nerve root compression. And so in January of 2020, he underwent an L3 and L4 bilateral laminectomies. And as you can see, the time frame between his symptoms kind of just keeps getting shorter and shorter. So by 6 months later, by June of this year, or excuse me, last year, he had worsening right-sided L5 radiculopathy and weakness. And again, an MRI confirmed that he had L5 nerve root compression by a disc herniation at the L4-5 level. And so on June 12th of 2020, he underwent a right-sided L4-5 partial discectomy and decompressive laminectomies. And that's kind of where our story picks up. So as I mentioned, he's got a little bit of other past medical history. He does have a remote history of urinary tract infection. It was probably more than 10 years ago. He doesn't really remember much of the detail on that. He has a very remote history of testicular cancer, for which he had resection in the early 90s. And then some of the other kind of common medical problems, some probably prediabetes, hypertension, some peripheral vascular disease, and multiple joints involved in osteoarthritis, as well as some hearing loss. His main surgeries have been the lumbar surgery. He does have a left total hip replacement and is eagerly awaiting having a right hip replacement, but that has been delayed by his osteomyelitis issues. And then as far as his as far as his social history, so he has a remote tobacco history, drinks a little bit of alcohol. Really kind of not much exciting. He's married to his wife of many years, monogamous relationship. In the past, he's now retired. He used to work as a tool and die maker, and then he later owned his own business. And part of the reason that he kind of got out of that is because of the problems with his back pain. So he eventually sold his business and is retired. He does have a kind of remote history of travel to China for a couple of weeks as part of his work, but mostly traveled throughout Western Europe. More recently, his only travel has been primarily south for a month in the winter. Now he primarily travels to Florida. However, in 2016, he did have one trip to Arizona. And he recalls actually having a lot of dust exposure during that trip. And while he was there, had to seek care for an upper respiratory illness. He's had no military service, and he's had no prior PPDs that were positive or any known tuberculosis exposures. So if you recall, his surgery was done on June 12th of last year. And initially, he actually did very well. He had almost immediate improvement in his back and his leg pain, and his incisions seemed to be healing very well. However, by about post-op day 15, overnight, he developed very abrupt onset of urinary frequency, so getting up 6 times that night to go to the bathroom, and as well as by the next morning, he was having shaking chills and diaphoresis. And so you can see his initial vitals from the ER, kind of most significant for the tachycardia and the fever to 101.7. He was satting well on room air, but he did not appear well. He was, kind of ill appearing and diaphoretic. Lungs were clear. He didn't have any CVA tenderness. And his lumbar incision looked very good, completely, still had his staples in place, but no erythema. You can see his labs, significant labs below, did not have a leukocytosis, but his CRP was pretty elevated. He had elevated lactate. He had a troponin leak that actually peaked at about 1.2 in the next 24 hours. But interestingly, even though his primary issues were this urinary frequency and dysuria, his initial UA and urine culture were both negative, as well as his PSA. And then blood cultures from admission did eventually, about 24 hours later, grew 4 out of 4 bottles of SERRATIA MARCESCENS. And it was pretty susceptible to the antibiotics that we would normally report for this organism. And I'll talk about that a little bit later. So he had, of course, some imaging. His chest X-ray kind of initially was concerning maybe for some right basilar opacities, but a follow-up CT chest looking for PE was negative and really just showed some bibasilar atelectasis. He really had no respiratory symptoms at all during that admission. He had a CT of his pelvis done, initially thinking that some of this pain and urinary symptoms could be pyelonephritis, but he had no fluid collections. He was found to have multiple right-sided renal cysts, and an incidental AAA, as well as some diverticulosis. And then he had these cysts that were confirmed on his ultrasound, but really nothing that looked infected, no evidence of pyelonephritis. The following day, he also had an MRI of his L spine, and that just showed some post-surgical changes. And I'm actually, this is one of the studies that I believe Dr. Spitzer is going to go through, so we'll get to see the images on that in just a couple of minutes. How did he do after this? So during his admission, he got the kind of ubiquitous empiric piptazo and vancomycin. He rapidly improved, felt much better within the first day or two. And while he was admitted, he had his staples removed, his incision stayed intact, and we actually switched him to ertapenem once a day, IV, put in a PICC line, and he was discharged home a few days later on the beginning of July. And about a week later, his SED rate and CRP were better. And then 3 days after that, however, when we saw him in clinic, he was now starting to complain of more lower back stiffness. And he had this new kind of erythema along his, this was kind of just a small portion of the midpoint of his incision, as well as some swelling here. So it kind of looks like it's a little bit bubbled up, like there's something brewing underneath there. About 4 days after that, this area actually broke open and started draining some purulent looking drainage. And although at the time his white count was still fine, his SED rate had bumped up a little bit and his CRP was 4. But remember, during his admission, it was almost 100. And so on the 16th of July, he had an MRI. Again, I think Dr. Spitzer will be running through the images here, but this one was much more concerning for progression of infection at the level of his surgery. So L4-5, osteomyelitis and discitis, as well as some probable phlegmon and fecal sac compression. So all in all, very concerning for progression from what we thought was maybe urinary tract infection and bacteremia related to that, to now also involving the surgical site. So on that day, on the same day of the MRI, he underwent a full surgical debridement down below the level of the fascia. They did remove some phlegmon from the L4-5 epidural space, but and the gram stain showed a few white cells, but no organisms. And we had pretty full cultures except for AFB cultures, and these were all negative. We actually held them a little bit longer than normal, and still nothing grew for us. We continued him on ertapenem. He completed a total of 8 weeks of therapy. And by the end of his treatment, and actually even a little bit before, his SED rate and CRP and his white count had completely normalized. However, by about a month later, so October, this past fall, he started complaining again of more stiffness in the low back in the morning. And he was starting to have, again, more right-sided radicular pain. His white cell count, SED rate, CRP, all still completely normal. By about a month later, he could basically just describe the pain as terrible. It was completely limiting his daily activities. He could only walk for about 15 minutes, and then he would have to stop and lay down on his left side in order to get the pain on the right to stop. Again, no fevers or chills, white count, SED rate, CRP, all still normal. And at this point, kind of in conjunction with his pain management team and his surgeon, we decided to go ahead and get more follow-up imaging. And I think at this point, I will turn this over to Dr. Spitzer.
Okay, so I have the MRIs for this patient. The top ones are the most recent, or the one from June, and then the bottom one is the most recent from November. I'm going to make the images bigger here as I go through each, but starting with the June exam, this was after the surgery that he had just had in earlier in June. And so this is L5-4-3, and then you can see that there's laminectomy site right here at 3-4. And here on the axials, so just to kind of give you a overview of where we are. This is the vertebral body. These are the facet joints. This is the nerve roots exiting through the neuroforamen, and then this is the thecal sac with the nerve roots of the cauda within the thecal sac. So this is intradural, and then this is epidural outside here. So this is fat within the epidural space, and then this is fluid within the thecal sac. And then this is the area of the laminectomy where you can see some T2 hyperintensity representing the fluid. And then this is the spinous process right here. And this is the musculature back here. And you can see that there's some postoperative change all in this area, which we would expect soon after the surgery. And then I'll bring over the post-contrast. So this is the T1 fat saturation post-contrast sequence. So when I say fat saturation, it just means that normally T1 hyperintensity is, or fat on T1 is hyperintense. And so when we give contrast, we like the fat to be lower signal intensity. So we saturate the fat out. And so anything that's hyperintense represents enhancement. So this is the area of the laminectomy. And you can see that it goes right up to the thecal sac, but it does not extend above or below that area. So this is all expected post-operative change. And then when we look on the axials, you can see this is the small fluid collection that has a little bit of enhancement around it. And then this is the thecal sac right up in here. So this is all expected post-operative change. This is likely a little seroma that is in the operative site, but there's really no indication here that we have an infection at this point. We can't rule out necessarily that there's an infection when we have a fluid collection here, but there isn't any indication other than just a post-operative change that there's anything unusual going on here. Oh, and one other thing is, so these are the psoas muscles out here, and you can see that there's a little bit of enhancement around this area, but otherwise it looks fairly symmetric and not a lot of enhancement within the psoas muscles themselves. Okay, so that was June, and then we have a July exam, and I think at this point the patient was experiencing quite a bit of pain. And so let me just, so at this point, what we have, so again, you can see the laminectomy site here at 3-4. And now you can see that there's a little bit of epidural thickening. So here are the nerve roots of the cauda. Here's the fluid of the CSF. And as you get down to about the level of L4, you can see here that there's a little bit of epidural thickening here. And then you can see the nerve roots of the cauda being compressed in this very narrow area because of the epidural thickening. And then when we go on our axials, you can see here again, you can see here's the thecal sac, and then you can see the front of this thecal sac being compressed by this area right in here. And so you can, on the left, you can see the L5 or the L4 nerve root exiting here, but on the right, you don't see that nerve root. You can just see a lot of hypointensity that could be either disc or it could be infection. And so this would explain the pain that the patient was having. And then you can see again the laminectomy site right in here. And then when we go to our post-contrast sequence, and I'll just keep this smaller here for a second, just so I can show you the comparison between the July exam and the June exam. And you can see the difference with the thickening and enhancement of the epidural area right in here, where here it was nice and smooth, and you didn't see a lot of that enhancement going below, where here you can see the enhancement coming up to the thecal sac and then being very thick below that level here. You'll also notice that there's new enhancement in the vertebral bodies, in the end plates, and going throughout the L5 vertebral body here. So those are all findings that are concerning for a developing discitis osteomyelitis. And on the axials here, you can see that there's a small little fluid collection in the ventral epidural space. That could be a small little epidural abscess that's developing. And you'll also notice that the psoas muscles have a little bit more enhancement and a little bit more edema. And so you just know that you have a little bit more reaction going on in the soft tissues around it. Now at this point, if you just have the imaging alone, degenerative change can often look just like discitis osteomyelitis. So on patients that are just outpatients coming in for back pain, if you see a lot of edema in the vertebral bodies, you see a lot of edema in the adjacent psoas muscles, that can just be degenerative change. But with the really thickened enhancement and a lot of the changes from the prior exam, this would, and I think obviously the clinical course would make you concerned that there's a discitis osteomyelitis occurring at the level of L4-5. And then the November MRI, so we have, again, we have the sagittal T2 sequence. You can see that the superior end plate of L5 looks like it has a little indentation here, and there's a lot of irregularity along the inferior end plate of L4. This is, again, probably the sequela of the discitis osteomyelitis. But one of the main teaching points with the imaging appearance of discitis osteomyelitis is that even though on imaging from June to July to November, it looks like it's getting worse imaging-wise, if the patient is being treated appropriately and is clinically improving as far as infection goes, then even though the imaging appearance is worse, doesn't mean that the infection is getting worse. And then on the axials, sorry, I gotta get the, okay, so we're at the level of 4-5, and you can see that a lot of that mass effect that we saw from the prior exam has resolved, and you can see that there's a lot more room for the nerve roots of the cauda equina within the thecal sac itself. And then the post-contrast sequences, you can see that you have quite a bit of irregularity along the end plates and enhancement, but you will notice that there's quite a bit of improvement of the epidural enhancement at the level of 4-5. So again, even though the disc itself looks like it's has gotten worse clinically, the patient, or it just doesn't mean that the infection is getting worse. It just means that this is sequela of the prior discitis osteomyelitis that is being treated appropriately. And then this is just the axial post-contrast sequence where you can see a lot of that enhancement again in the epidural space has resolved. The patient also got a gallium scan in December. I'll just bring that up quickly. Okay, so so these are just, so this is obviously the whole body, and then these are oblique views of the lower lumbar spine in the area of concern. And it's actually, it was read out as discitis osteomyelitis at L4-5, but the findings are very, very subtle, and you can just see that there's a little bit of increased activity right in this area in here. But again, the findings are very subtle, and this is actually a good indication that knowing what the MRI shows, that you do have a little bit of activity, but the activity is very, very subtle, so that it's an indication that the treatment is actually working. Though even though the MRI, the last MRI that we saw looked pretty nasty along the end plates, this is a good indication that the patient is being treated appropriately. This is just some more images, again, just showing a little bit of that activity right in here where we know the discitis osteomyelitis is. And that's all the imaging that I have. If I'll be here for the end if anybody has any questions specifically about the imaging.
So while you're stopping your sharing and Dr. Hinkle's getting back on, I don't know, Dr. Hinkle, did you notice that Dr. Boev is online? So if you need,
hi guys.
If you need comment on surgical findings at any point, he's there.
Yeah, so good morning, guys. This is this is a pretty challenging case. As you heard, the man had an extensive back history with back pain. And can you guys see me? Okay, there you go. He had a couple of operations, and every time at different levels. He did very well after his surgeries. They were all simple decompressive procedures without hardware. This most recent time, and I want to thank the whoever did the initial presentation. I was struggling with my Zoom capabilities here, but did a phenomenal job at describing the clinical course. And thank you, Dr. Eric, for going over the images in great detail. What was surprising in this man is that he came with an fairly unusual post-surgical infection bug, a gram-negative organism, and that his initial MRI scan or presentation was essentially what you would expect to see post-op without issues. The reason I did not immediately go and wash him out is because he did not have the back pain, which is pretty common. I mean, one of the hallmarks of a post-operative discitis osteomyelitis is excruciating or significant amount of back pain, out of proportion frequently to what you'd expect for the post-operative course of a patient. He did not have that. That's the reason why I didn't go after a washout immediately, because his incision was healed, didn't look bad, and he didn't have the excruciating back pain. We also had an organism, and we're treating. In retrospect, I've spoken with the patient numerous times, and I'm not sure about his UTIs. I mean, it seems like he carried a history of that, but there was a concern that this could be an operative site infection or whatnot. So on the moment he started having any sort of issues with back discomfort, and he did develop what looked like, he never reported significant drainage, but a small 5 millimeter de novo, almost like a small dehiscence with granulation tissue in the middle of the incision, which is quite unusual. And that's why I took him to the OR the next day after presentation. Knowing that he had been treated for the bacteremic state and really wanted to not only culture, wash out any potential bugs there, but wanted to make sure there wasn't a different kind of bug that had developed, and that these two things potentially were unrelated. As was presented earlier, his cultures were all negative. He eventually went on he healed very well from the washout. It was an uncomplicated procedure. And as Dr. Spitzer pointed out, sequentially on imaging studies, he showed radiographic improvement in that regard. I just wanted to add two comments to Dr. Spitzer's presentation. The last MRI scan he showed with irregularity of the end plates is, as Dr. Spitzer pointed out, quite common in the setting of osteomyelitis and discitis. But those patients, those changes typically lead to an autofusion. We place those patients in a brace when they ambulate, and the bones will eventually progress to fuse at that level by themselves if you give it enough time, and their back pain gets better. In this case, the patient continued to complain of back pain. His radicular symptoms, even with that MRI, the second MRI scan, which triggered the washout, really were not very impressive, despite what the picture showed, which were impressive. But be that as it may, he healed from the washout. His numbers all corrected, but he continued to complain of back pain. So Dr. Hinkle and I went back and forth about this patient care and followed him very closely, stayed in very close touch. And ultimately, we decided to pursue a CT-guided biopsy of the disc space, which was done in the very beginning of January. The teaching point in that is that rarely, on very rare occasion, P. acnes can be a bug, which is a gram-positive organism, as you all know, can be associated with a surgical infection. It's a much more indolent presentation. We see it in ventricular peritoneal shunts. And I actually have seen, not in my home practice, but others present cases very similar to this, where they never had to do a washout, but patients continue to have back pain unusual for their initial pathology up to 2 to 2.5 years out, and a CT-guided biopsy actually presented with was positive for P. acnes. In those cases that I mentioned that are fairly isolated, the numbers remained normal throughout. CRP was normal, the white counts were normal, and the only reason that was performed is because of the radiographic appearance, but mostly the patient's symptoms. The reason for the CT-guided biopsy, which I think was the right thing to do, is Dr. Hinkle and I wanted to put to rest the thought that the patient may have a different bacterial bug infection, specifically P. acnes, which would, again, can give you normal lab numbers, laboratory values, but continue to cause the back pain that's associated with the ascites infection. We did pursue a CT-guided biopsy / culture of the disc space. As you all know, the P. acnes cultures are required to be grown for at least a 10-day period. Those were kept for 14 days per our request, and thankfully, unfortunately, they've all come back negative. So the patient's pain is most likely biomechanical in nature from the presence of the ascites and the osteomyelitis he had developed in that region, even though the infection, I think we have clear confirmation, has grossly resolved and has been resolved. So what we're doing at this point, and I just saw the man the other day, he does not have radicular symptoms in the leg very much, at least not compared to what they were before surgery. He has some buttock referred pain, at least on his most recent visit he did. But the biggest complaint remains the back pain. And so there's alternatives to this. We've discussed, you're in a somewhat of a catch-22. Someone who did have an osteomyelitis infection, even though the cultures have been negative clinically and radiographically, you have to, he did. And the cultures were negative, in my opinion, because we treated the bacteremic state. So, you have to be careful about doing cortisone injections or epidural shots or anything of the sort in a space that's been previously infected, even though now confirmed to be clean. So we've discussed different alternatives here. He's been wearing a brace when ambulatory. But certainly one option here, if his pain does not get better, would be a neuromodulation approach, which is a spinal cord stimulator placement higher up in the thoracic spine to alleviate his chronic back pain. And that's on alternative treatment we have potentially discussed. He's done a lot of research on it. He's eager to at least do a trial, but Dr. Hinkle and I are staying in close touch as far as getting him, quote unquote, cleared, whatever that means. I think we've not left any stones unturned here, but to make sure that he's optimal for that approach of treatment, course of treatment.
All right, so we should let Dr. Hinkle continue with her slides. You want to?
Thank you so much, Dr. Spitzer and Dr. Boev. I wasn't sure we were going to be able to have everyone on board this morning. So that actually takes, there was a great summary by Dr. Boev that actually kind of covers what the next couple of slides are that I had. As he mentioned, the patient did actually have a CT-guided biopsy. Multiple sections that were taken. This was done early January. That also did not show any white cells or any organisms. The cultures were kept with the intent of an indolent organism. They were kept for 14 days. And I kind of endlessly harassed our micro lab during that 14 days, trying to make sure that we didn't grow anything. And you can see the pathology report that came back. And speaking with Dr. Haddam in the pathology department, this was actually relatively firm and sclerotic bone that they had for a sample, and really didn't show any evidence of acute inflammation. At our request, he did go back and do kind of separate organism stains, so looking for things like fungal organisms, and those were all negative as well. So that's just kind of the general flow of how we pursued his workup. Oops. There There we go. Okay, so I can kind of skip this slide as well, because this is kind of where we were left. It was the now what question. We had kind of multiple.
I think we lost your audio, Dr. Hinkle.
So I will keep moving on. So what I wanted to try and get through here is just a little bit of review about vertebral osteomyelitis, and hopefully not be too boring for everyone. It's not a lot to take in. Just kind of a reminder that even though sometimes it probably seems like more of the osteomyelitis that we see, vertebral osteomyelitis in adults in general in the US is probably about 3 to 5% of the total. In patients that are older, over 50 years old, most commonly this is hematogenous. And in the elderly, it's a fairly common form of subacute osteomyelitis, probably second only to the prosthetic joint infections that we see. And I think most of us are very familiar with kind of the hematogenous mechanism of how bacteremia from another source, maybe urinary source, endocarditis, IV drug use, it eventually is able to seed the vertebrae, and then from there also involve the disc space. So that I think is a very common and very well understood mechanism. There's also the potential for iatrogenic infections, of course, so post-operative, but kind of in the era of antibiotics and peri-procedural antibiotics, this is actually a pretty rare, including epidural injections as well. And then there's another mechanism, at least theoretically, that would kind of probably sends most of us back to the anatomy atlas and understanding something referred to as the Batson's plexus. And this actually comes into play probably in patients like this gentleman. So it's this network of valveless veins that connects directly kind of the epidural space as well as the pelvic veins. And so you can kind of see in the background here. So this is actually thought, at least theoretically, to potentially predispose, especially male patients with a history of urinary tract infection, prostatitis, to kind of a direct line between, a direct line for infection to travel between the pelvis and the vertebrae. So just interesting, and not something that we've probably any of us have thought about since medical school. So the typical pathogens, we'll kind of talk about the typical ones first, or the pyogenic organisms. Just remember that these types of infections present generally with pretty rapid destruction of the tissue, but they're usually limited to a single disc space and then the adjoining vertebrae. The most common organism that we all see is Staph aureus, by far and away, in the United States. And so you can see the kind of the typical golden colonies and the gram-positives in clusters, the gram-positive cocci clusters that we see. Coag-negative staph, streptococci are also fairly common, as well as the aerobic gram-negative rods. And it's interesting in looking at multiple studies kind of worldwide. In general, it always seems to be about somewhere around 20% of cases. So not enough that we can really ignore it in our empiric antibiotic choices. Definitely something that you need to consider, but it's just not the most common. They're not the most common organisms. We also have to consider the atypical pathogens, right? So this is not an exhaustive list by any means. Just kind of the concerning things that we should think of. And I would argue that these are the types of organisms that, the first clue you're going to get is from, doing a pretty thorough history and physical on the patient, understanding, their travel history, their dietary habits, animal exposures, that kind of thing. This is what we often are asking the residents when they're presenting cases to us. So the first pathogen kind of atypical pathogen we think of is Mycobacterium tuberculosis. Not something we see a lot of in the United States. It tends to have an indolent course. Pot disease has an indolent course. It's interesting, it tends to dissect along tissue planes, and so sometimes even vertebral infections can actually present with masses in the groin as it kind of tracks down those tissue planes. And typical for tuberculosis compared to pyogenic organisms is that it will involve 2 to 3 vertebral bodies and disc spaces. So you can kind of see in this older X-ray involving both the 7 and 8 vertebrae. It's an organism that likes areas of high oxygen tension. So this includes the vertebral bone. And at least in adult cases that we see in the US, most of them are actually probably seeded at the time of their initial infection. And there's probably a transient bacteremia that happens. And then the disease is actually reactivated later in life, either due to osteoporosis or trauma and the waning immune defenses of the host, kind of typical for what we think of as with pulmonary TB. And this often will occur in the concomitant setting with pulmonary disease. It's interesting, as I was kind of reviewing this from a pediatric standpoint, in areas of the world where TB is endemic, it's actually not uncommon for children to present with vertebral involvement of TB during their initial infection. Other non-tuberculous mycobacteria, so MAC is probably, again, it's a very rare type of vertebral osteomyelitis. Kind of one of the classic cases to maybe think about is in HIV patients who are presenting with new back pain and maybe, fevers and progressive debilitation in the setting of immune reconstitution after they've restarted or started antiretroviral therapy. So as the immune system really starts to kind of kick in again and kind of cause destruction as well as it responds to the organism. And then, I feel like the manifestations of brucellosis could be an entire lecture on its own. It's another one of those organisms that really, after good history and kind of understanding what the patient's travel history has been, would lead you to think, okay, maybe this is something that could be a problem. It tends to also be a very indolent, progressive type of vertebral osteomyelitis. And in the US, of course, it is very rare and usually limited to patients that have come from overseas. But it's interesting that, in other parts of the world where it is endemic, this actually accounts for probably up to a third of vertebral osteomyelitis cases. And then there's, speaking of atypical pathogens, we can't forget fungal infections as well, too, although, again, in general, these are very rare in the United States. Includes the endemic mycoses, so things like coccidioides in the desert Southwest, histoplasma, which is a lot closer to home, blastomyces. Again, these are not organisms that are probably going to come to mind unless you have the history in the background. Immunocompromised patients, very rare, but Aspergillus is a reported organism that can involve the vertebrae. Of course, in our IV drug using population and patients that have chronic indwelling catheters, like our dialysis patients, you also have to consider that these can be polymicrobial infections, and it can include both fungi and bacteria, as well as more environmental organisms. And just kind of a small example, I'm not sure if anyone else remembers that there's an epidemic of fungal meningitis and vertebral osteomyelitis that happened in the 2012-2013 timeframe. And it was related to patients that had received epidural injections with contaminated methylprednisolone that had been manufactured by the New England Compounding Center in Massachusetts. And the predominant organism that was isolated from these patients and from the contaminated medication was something called Exocerohilum rostratum. And it's a black mold, a pigmented mold, actually has melanin within the cell walls that turns it that color. And in the end, because this product was distributed so widely throughout the U.S. and the world, kind of the final tally was over 700 cases of meningitis, discitis, vertebral osteomyelitis, and septic arthritis in patients that had been used for joint injections. So, and again, it was one of these situations where once the kind of the first case was reported, it was very widely reported afterwards, including kind of the final summary that was in the New England Journal. So in terms of the presentation of vertebral osteo, I think we, all pretty familiar. I think, maybe even more familiar to our outpatient colleagues is, the early signs of vertebral osteo can be frustratingly nonspecific and really not associated with any physical findings. So it's patients complaining of kind of muscle spasm and stiffness in the morning. Oftentimes they get labeled as narcotic seeking, right? So this can end up in delays of diagnosis of anywhere on average about 2 to 4 months, or an initial misdiagnosis, especially if it's a patient that has a history of malignancy. The later signs are a little more suggestive, right? So the fevers and chills, but again, maybe only about half of these cases will present with, even with pyogenic bacteria, will develop clear fevers and chills. And that's actually very rare with the atypical organisms. As things progress, they kind of look, again, a little bit more nonspecific, not feeling well, weight loss, not eating. And then the radicular symptoms, I think as Dr. Boev mentioned before, tend to be much later and associated with the real changes in the anatomy. Just some keys on exam to look for, oftentimes when we ask patients, does your back hurt? They'll either say, yes, it hurts all over, or, it always hurts. I always have low back pain. And so kind of probing a little bit more to ask, okay, is this any different? Is it different in location? Is it worse? That can help. And with vertebral osteo, it's not this all over pain. It tends to be very localized pain, can be worse with kind of percussing over the area. It can radiate to other parts of the body, depending on the level, the abdomen, lower extremities, and the groin. They tend to have very limited range of motion of the spine. And then, later on, especially if there's extension of infection into those paravertebral muscles, patients will start to complain kind of a new layer of pain in terms of muscle spasm and tenderness. Kind of try and keep an eye on time here, we'll go quickly. So in terms of diagnosis, really clinical suspicion really has to be raised based on the history and the exam like we talked about. You certainly want to pay attention to any history of urinary tract infections and bloodstream infections within the last year even, because this can be a very slowly progressive disease. Any signs of endocarditis, portals of skin entry, injuries, IVs, that kind of thing, and then the physical exam findings that I mentioned before, and especially paying attention to any signs of neurologic compromise. Supporting evidence that helps to have from lab work. So when you're initially working up these patients, definitely want to look at the cell counts, which can be normal though, up to about 40%. SED rate and CRP actually are very sensitive especially in the setting of back pain, assuming that there's no other obvious sources for those elevated markers. Definitely want to get 2 sets of blood cultures before antibiotics if possible. And, as we'll talk about later, really holding antibiotics in these patients that are not septic up front is very helpful to culture yield in the end. Blood cultures may only be positive about half of the time, but you can actually ask the lab if there's a concern for these indolent organisms like Brucella to hold them for longer. And then based on your history, you think about other tests. So, in IGRA, which are actually better than a PPD in this situation, and then other serologies like Brucella and the fungal serologies like we talked about before, and all to help kind of, fill in the gaps of trying to diagnose this. Imaging is very important, as Dr. Spitzer was talking about before. I'll just kind of say that plain films, I think initially are oftentimes obtained in the outpatient setting, and that can be helpful, especially if the pain has been going on for a while, but they tend to be nonspecific, right? And they don't really help as much in terms of differentiating from things like compression fractures, tumors, and sarcoid, and that kind of thing. MRI is your best bet. And in terms of sensitivity and specificity, there have been several cases that we've been involved in here in the hospital where we have someone who presents very early on with pain, but their initial MRI is not very specific. We wait about a week and a half, 2 weeks, and then we actually start to see the progression, and that's more helpful. So it can be helpful to repeat the MRI if the suspicion remains high. The gallium scan we talked about before, I just always find these interesting because of the way it probably works. Gallium being similar to iron, it works by binding to the neutrophil lactoferrin and bacterial siderophores. So this is probably the mechanism behind this. And when combined with a bone scan, the sensitivity and specificity for vertebral osteo is actually very high. Less so with an indium tagged white cell scan. So that's why we pursued the study that we did. Biopsy. So I think probably everyone understands why this would be the gold standard for trying to diagnose vertebral osteo. It depends on kind of the sample that is obtained. The image-guided fine needle aspirations obtain a much smaller sample of tissue, but it's faster to get and less risk for the patient. But if those are not diagnostic, you may need to consider moving on to a surgical biopsy. It's important for cultures, but even if the cultures are negative, the pathology is also very helpful in terms of looking for acute versus chronic inflammation, malignancy, especially in this patient that had a history of testicular cancer, And if it's non-diagnostic, the recommendations are that we actually can sometimes pursue these again, another sample from another site. However, just keeping in mind that in the setting of a suggestive history, positive blood cultures with a likely organism, and elevated SED rate and CRP, we don't necessarily have to proceed to biopsy. Okay, so management, I think probably first off, and should be the first in everyone's mind to think is surgical if there's any evidence of neurologic compromise or spinal instability. If there's evidence of epidural abscess and cord compromise, if they have intractable back pain, and if there's persistent infection despite antibiotics. And these are oftentimes the cases where if they have paraspinal muscle abscesses that are progressing despite being on antibiotics, then we need additional help. The antibiotics alone won't fix that. And then antibiotics, again, I just want to, reiterate the importance of holding on antibiotics, getting those blood cultures first. If there's any chance that there's going to be something that we can biopsy, because that's really going to be, that's going to help us focus the antibiotics a lot more. So the antibiotic regimens, empirically, we kind of want to cover the most likely organisms: Staph aureus, strep, aerobic gram-negatives. A typical regimen should include something like vancomycin plus, so it's either third, fourth generation cephalosporin, ciprofloxacin, maybe even a carbapenem, especially if this is someone that has a history of an ESBL producing organism. If you have patients for which vancomycin is not ideal, then daptomycin is a reasonable alternative for the staph and strep coverage. And then this is a really busy table, but I like to kind of carry these pictures of tables in my mind. This is actually directly from the IDSA guidelines for vertebral osteomyelitis. And I like it because it's very thorough, kind of runs down the most typical organisms, including the Enterobacteriaceae, like we were dealing with in this case, and laying out alternative for once you know what the organism is. Okay. So in terms of duration, I think everyone's familiar with, typically we'll recommend at least 6 weeks of adequate antibiotic coverage. What this also means is assuming that there's source control as well. In some cases, we will push for a little bit longer, and this is supported by kind of expert opinion. These are typically cases of resistant Staph aureus or patients that had very extensive infection, or maybe they were not able to get surgical drainage. There are some studies that support switching to oral antibiotics after at least 2 weeks of IV antibiotics, but there are some pretty important caveats that kind of limit our ability to do that in many cases. And so this is assuming that the person has a pretty significant improvement and their CRP is declining, assuming that they've had kind of source control, surgical drainage of any paravertebral abscesses, and also assuming that you can use that there's susceptibility to a highly bioavailable oral agent. I'm going to get to that in the next slide. And then probably the most problematic thing that I find sometimes in our consults is making sure that, okay, so say we meet all those first 3 criteria, is there any contraindication to using the oral medicines that you need? For instance, with linezolid, great, very highly bioavailable medication, but it has a lot of medication interactions and it has a potential for serotonin syndrome. We're using it in patients that are also on SSRIs. Fluoroquinolones I actually chose not to use in this gentleman's case because we had detected the abdominal aneurysm on his CT. And then Bactrim, of course, can be very problematic in our older patients that have impaired renal function. So this is just another table that kind of talking through some of those oral agents that may be appropriate depending on what the organism is and depending on your patient. And so how do we classify, how do we need to follow up these patients? Unfortunately, there's really no kind of standard definition for who's considered a treatment failure. Microbiologic recurrence or a positive culture is probably the most definitive, right? But we often don't have that. The clinical response is important, and that's probably most important to the patient, how they're feeling. SED rate and CRP actually are very good at predicting who's a high risk for failure. So if you've had a very significant drop in the SED rate by about 4 weeks into therapy, unlikely that these patients are going to have microbiologic failure. And we don't recommend, I often get the question from patients and families, don't I need another MRI to make sure this is gone? For exactly the reason that Dr. Spitzer pointed out before, the images will often look better or look worse early on, and this is not the way to go. The way to go is what we did in this case, which is, if he develops worsening pain, new neurologic symptoms, concern for, a change in the anatomy, then that's when you should pursue it. Quickly about SERRATIA. This is a gram-negative rod, Enterobacteriaceae. It's got this cool red pigmented color sometimes. It's a concern to us in the hospital because it's an environmental organism that's often isolated from water sources. And so it usually counts for somewhere around like 2 to 5% of nosocomial infections, like urinary tract infections, catheter-associated infections, and rarely even, presentation like this. This organism can actually have antibiotic resistance due to a beta-lactamase production. So that's the reason why you'll see restricted antibiotic reporting. We're not going to report, the third generation cephalosporins or lower than that because of this risk for beta-lactamase production. So that was the reason that we actually chose ertapenem in this case. And in terms of other types of gram-negative vertebral osteo, it started really, there's not a lot of cases in the literature. A lot of them have to do with the more typical organisms and are found in IV drug users. There was kind of two sources that I found that were very interesting for SERRATIA marcescens. One case series had 2 cases that had developed this after they had spinal trauma and then subsequently complicated by SERRATIA bacteremia from another source, either urinary or biliary. And very similar to our patient, the patient that had a urinary source of their bacteremia presented with their vertebral osteo about 3 weeks later. The biliary source was about 2 months out. So the presentation between the bacteremia and the vertebral osteo can be delayed. Very similar situation in another very recent case report of SERRATIA vertebral osteo in an IV drug user who developed it about 3 weeks after developing an abscess at one of the injection sites. So Dr. Boev kind of already gave us a follow-up. He's seen this patient as well more recently. We continue to basically follow him off of antibiotics. His SED rate, CRP are still normal. He's kind of working through the pain. I think you mentioned to me the last time he's also doing a little bit of physical therapy. Interestingly, I don't know if anyone caught that in his discussion of his prior medical history, kind of came to light that he had some travel and maybe some concern for these endemic mycoses. So I actually did more recently do some serologies on him that were negative for COX-C. His histoplasma serologies were indeterminate, so I'm going to repeat those. And he's really just kind of working with his pain management team, and we're considering doing a spinal stimulator. Okay. So I actually want to leave. We're just about out of time. I just want to thank everyone for your attention, and there are many people involved in this case and in his care over the last year. Especially want to thank Dr. Spitzer and Dr. Boev for helping me present the case today. And especially for any of our outpatient colleagues, I just want to make sure you have my contact information. And I kind of feel like in our line of work, I have to remind everyone to, stay safe, and stay well out there. Wash your hands, do all that. If my 9-year-old can do it, we all can do it. So I'm happy to take any questions at this point.
Thank you. That was great. Looking at the chat line here, I think you answered the one question about CRP already. Yeah, I think we covered it, and we're just about out of time. So thank you very much.